Welcome to AETCM, the emergency medicine channel. So we are following that skill drill portion. Today's our topic again same medication administration. In the third part, we are going to see the IO intraosseous insertion and then infusion technique. So ideally, before getting into the topic means procedure, we'll see some indication, contraindication. What is mean by intraosseous infusion or intraosseous insertion? First, intraosseous in the sense we are going to inject the drug or we are going to deliver the drug inside the or within the bone marrow. So that is the definition for the intraosseous infusion or intraosseous medication administration. Second thing, it is an alternative technique for the IV access. Means why we are telling like that means here the vein will be, so because of that bone matrix, so the vein won't collapse easily. Means so assume in the case of cardiac arrest or in the case of any traumatic shock, hemorrhagic shock, or if the person in a burns, because of the burns, if the person getting into the dehydration, in that cases that will be if you want to obtain the IV access, that will be more difficult because of the reduced volume or less volume, the vein easily will collapse. But what in the case of intraosseous means, there because of the presence of bone matrix, the vein easily it won't collapse. So that is why we are telling intraosseous is an alternative technique for the intravenous access. Okay, this is second thing. Third thing is your another name for the intravenous access. It is a non-collapsible vein site. Okay, that is why we given this much explanation, non-collapsible vein site. Fourth one, what is the indication for the intraosseous access? So indication, as like I told, it is mainly in the case of cardiac arrest or in the case of extensive burns or dehydration, or if the person lost hemorrhagic shock. So those are the things. Whenever the vein is collapsing, we are unable to obtain the intravenous access, we can choose intraosseous access as an alternative site. Second most important thing you have to remember, when we should not perform the IO access, that is a contraindication, right? So contraindication wise, first initially if the person have any local infection, so at the insertion site, so we have some insertion site, at that site if the person have any local infection, there we should not, or if the person have a fracture in that same limb, there we should not. Third thing, if any congenital abnormalities like anomalies like osteo imperfecta, or if the person have any osteogenesis, osteoporosis, so those are the condition also we should not perform. Or if the person, if you are selecting as a below knee or proximal or distal tibia, already the person have a like a bilateral knee replacement, means that is also we have to avoid in this limb. Alternatively, you can go for the another side, or you can think about the other route of drug administration. So these are the contraindications related with your IO access. Then moving on to the next step, that is what are the articles I want to arrange before the IO access, or what are the minimum requirements I needed for the IO access. Okay, so here ideally you need first regarding your antiseptic precautions. So for that you need a personal protective equipments, gloves, mask, everything. And then site preparation. For site preparation you need if you have a sterile dressing tray or sterile tray, means you can keep and then you can carry forward. Then you have to go with your antiseptic solution, that is chlorhexidine, or you can choose the povidone iodine solution. Then you have to select the your needles, so syringes. So you have to take ideally 10 to 20 ml of flush, you have to take normal saline flush to flush up the line or to verify the line. And then third one, if the person is conscious or conscious to you, means orient to you, means if needed you can go with an anesthetic agent. So ideal agent is lidocaine you can take, or if the person you want to give a parenteral, so if you have a parenteral, ideally parenteral we can't obtain, that is why we are choosing this one, right? So anyway, here you can select the lidocaine is an ideal agent that you can select. Then main important hero here is an IO needle or the IO needle, that is the main important thing. So IO needle wise we have a three type of sets we have, means our three type we can classify. First one, manually operated device or manually insertion needles. So this is the manually insertion needle, here I have. So this is one of the needle you have, or else one more device we have, that is the battery operated device. means it commercially most of the area we are using like the name called EZIO needle. So that is the battery operated, that will be like a drilled one, so you can place over the bone area and then you can drill and then you can inject. That is the second group. Third group, that is will be big all bone injection gun, means that will be like a, it will be a simple operated device, so you have to place exactly over the site and then you have to proximally pull up, so it will give a one click, thereby the gun will inject, so it will be like a spring like model, so it called bone injection gun. So these are the three variable commercially we have a device in that market. So first one, manually operating device or manually inserting cannulas or devices. Second thing, needles. Second thing, your bone injection gun. Third thing is your battery operated devices, EZIO needle. So these are the article we have to set up. Okay, then we'll move on to the next thing, how to insertion, what are the various sites we have in the IO insertion. So site wise, we have commonly we are going to pick the long bones. Okay, so long bones wise, first is our long bone is a humerus. So here the proximal head of the humerus or proximal humerus part we are going to pick, that is the first site. Second site is your manubrium of the sternum. So the top portion, right, the manubrium of the sternum we are going to select. Third site is your distal femur. Okay, femur, in femur, distal portion of the femur, and then coming into the tibia, there we are going to select the proximal tibia and then distal tibia. So these are the common sites for the IO insertion. First, it is a proximal humerus, and then your manubrium of the sternum, distal femur, proximal and then distal tibia. So these are the sites. So the first site, that is your proximal humerus, right? So ideally where we are going to place our needle means it is a greater tubercle of the humerus. Okay, so how we have to locate the area means, first you have to ask the person to place, adduct the arm, and then you have to ask the person to place his arm over the abdomen or chest. So this is the way we are internally rotating the humerus. Okay, so this is the way we are internally rotating. Then ask the person to relax his arm. So ideally you have to place like this. Then one hand, so this is the ulnar surface of the hand, this hand should be placed over this area, so middle of your deltoid. One more hand over the anterior aspect of your axillary line, so it is an anterior axillary line, here you have to place. Then adduct your thumb. So one hand, one ulnar aspect of the hand over mid of the deltoid, one hand over the anterior axillary line, then adduct your thumb, thereby you can palpate slowly. So here you can see the head of the humerus, followed by you can feel the one dimp. So the curvature, your humerus head curvature you can see. So there ideally we are going to place our needle. Okay, so this is the way you have to perform in the proximal humerus. So ideally the needle will prick on the greater tubercle of your humerus. So this is for the your proximal humerus. So second site is your manubrium of the sternum. So actually for manubrium of the sternum, commercially we have a device like this. So this here you can see the exactly sternal notch, and then this is the portion of clavicle. So this is the manubrium of the sternum, right? So in this, here they mention some A point, right? Here only we are going to prick our needle. Or in some other devices, how they will it is press we have means, here you will get a one hole, or here we will get a one portion, so round portion, there we are going to place our needle. So this is the way for the commercially we have a ready-madely we have our these are the device we have. It is very easy to place. So how to place means, so it is very simple. So just to follow this curvature of your sternal your notch, so just place over the sternal notch, just to paste it and then go. So it is while doing an your sternal IO axis, you have to go behind the person, so it will be easy for you to push up. So here all the things we are going to perform with the manually operated devices. So ideally you have to hold like this, and then you have to with a 45-degree angle you have to push into the person. So here For every site, here I am mentioning only the sites. So procedure wise, it is same like your IV access. So first you have to place, means you have to locate the area, you have to mark the area. Then with your gauze and then antiseptic solution, we have to clean the area from center to periphery. Or in some other institution, they will follow all the painting drapes they will do. So based on your local protocol, if it is draping needed, means with the draping you have to do. Or else if it is an emergency, you have to perform you are in a pre-hospital site, means you can do with a chlorhexidine center to periphery, and then you have to allow for the dry, then you have to push your needle. So insertion wise, once if you are entering into the cortex part, so first initially you will feel some hardness of the bone, because we are penetrating the bone, right? So once after that, in middle of the area you will feel some pop out, or you will feel some easy flow of the cannula or easy flow of this needle. So there we have to stop ideally, then you have to remove this stillet. Then you have to connect your whatever drugs you are going to connect, so that you can connect, or you can connect the fluids. So I just remember, first clean that area, sterilize the area, then allow it for the dry. Then after dry, you have to place the needle in a particular area, you have to give some pressure. So with that, first it will be like a harder, because we are penetrating, or we are drilling the bone, cortex part of the bone. So once after your once you cross the cortex, you will once you reach out your medulla portion, that will be like a spongy portion. So may feel like something like a pop out, or you will feel like something easy flow of your needle. There you have to stop, and then you have to remove your stillet, then you have to proceed for the further infusion. So this is where we stopped, means so this is for your ideal thing for your sternal. Okay. So third thing is your proximal tibia. So still now we seen some examples, so how we have to locate in the adult cases. Now we'll see in the pediatric cases. So here itself I will explain the adult also. So why we are more specifically I am concentrating on proximal tibia and distal tibia and pediatric, means because this is the ideal site which will perform in the pediatric. Okay, so that is why we are focusing. So proximal tibia, where we are going to place our needle, means first palpate the patella, followed by just come distally, and then palpate the first bony prominence. You can see that is the your tibial tuberosity. So from the tibial tuberosity, 1 centimeter below, so or 1 centimeter below, and then 2 centimeter or 1 centimeter medial, there we are going to ideally prick our needle. So again, from the patella you just palpate distally, then one area you will feel the bony prominence, that is your tibial tuberosity. From that you are going to palpate 1 centimeter, or you are going to move 1 centimeter below, and then 1 centimeter medial to the body. So here this is the ideal site. Here I am going to prick my needle in a 90-degree angle. Okay, so in a 90-degree angle I am going to prick. Why we are avoiding this tibial tuberosity, exactly in a tibial tuberosity, means pediatric cases have in a proximal and a distal region, they have a growth plate. So without damaging, or to avoid that accidental prick of your growth plate, we are choosing the 1 centimeter below the tibial tuberosity. How we are to perform in the adult cases, means just in the tip of the distal end of our inferior part of your inferior tip of your patella, there you have to place your 2-finger breadth. Okay, from the 2-finger breadth, so below the 2-finger breadth we are going to prick the needle, but the pricking should be 2 centimeter medial to your body. So 2 centimeter medial from the 2 centimeter medial to your where you pointed that finger breadth. Okay, this is the thing for your adult cases. Then coming into distal tibia, that is your where we are going to place, means this is medial malleolus, right? So from that medial malleolus, 2 centimeter above, that is the ideal location for the pediatric and then adult cases. So nothing but, so this is the medial malleolus. From that 2 centimeter or 2 to 3 centimeter also you can go. So in the case of pediatric, you can avoid growth plate injury. So 2 to 3 centimeter above, that is the ideal location, there we are going to place our needle. So this is regarding the proximal and then distal tibia. What we are going to tell in that femur, means femur is nothing but, so in adult what we did, 2 finger below. Okay, the same thing in the proximal tip of your patella, there you place your 2 fingers. In that above you are going to place your needle. So it should be in a medial only, not like a lateral side. Okay, everything should be in a medial. So this is overall idea regarding the various sides. So we started from the proximal humerus and then sternum and then proximal tibia, distal tibia and then distal femur. So this is the idea regarding the where we have to prick the needle. So we shown the 4 various sites, right? So here one thing you have to remember, in compared to your IV, here you may feel some resistance in IO axis while delivering a drug, or at the time of your confirmation of this time, you may feel some resistance. So that will be normal. So make sure you are giving the flesh. So if you are not confident enough whether it is exactly in that area, means if you are not confident enough means you can remove. But if you are feeling some resistance means just to give some amount of 10 to 20 ml of flesh, then see for the signs of extravasation. Or you can give the some amount of drug or fluids or 100 ml something, you just give. After some time you just check for the extravasation. If extravasation is there means definitely you have to remove, or else it is normal only because it is in the bony cavity, right? So you may feel some resistance compared to your IV. Then moving on to the last part, that is your complications. So complication wise, here also the same thing. If you are not following any aseptic precaution means ideally it will cause the infection, inflammation. So it collectively we called as a osteomyelitis. Then coming into the next part, that is a fracture. Again here also fracture can happen. Third thing, you are if you are accidentally prick the growth plate means it can cause the growth plate injury. Fourth thing, through and through penetration means it will start one area in a proximal route, distal route it will come out, means when it will come out means you are not realizing. So when if while pricking we told, right, you will at one point you will feel some pop out, or you will feel like easy flow of the cannula. You are not aware about that, but still if you are injecting or if you are giving a pressure of inserting means it will come through the distal area, that is called the through and through penetration. That is also can happen. And then remaining complication, that is what are the things will occur in your IV, the same thing also here also can occur, means thrombophlebitis can occur, extravasation can occur, infectious transmission can occur, and then you can tell us a fluid overload. So those are the all the things, electrolyte abnormalities, whatever things can occur in the IV, here also chances are there. So these are the overall idea regarding your IO axis. If you have any doubts or clarification, or if you want to update anything for us means, so we are happy to hear. Those are the things. So do your best. Shalom.